kind of rediscuss some things if we need to. All right, let's get started. So talking about the muscles today, and again, this is a pretty short lecture. The first thing we're going to talk about are muscle injuries and things that we can see in our patients who develop injuries to their muscles, and this is a pretty common thing that you're going to see in clinic. So the first one is rhabdomyolysis. So here, this is typically due to some type of trauma or injury to the muscle cells, right? So think about patients who either get some type of damage where something falls on them, and that object is compressing their muscles and their legs. And so that when that happens, it's going to cause issues with blood perfusion to those muscles. And over time, those muscles are going to start to die. And when they die, they start to release their contents. Now, that's not the only way this can happen. And probably more commonly that we're going to see in clinic are patients who have overuse injuries. Okay, cool. Thank you. Thank you. Patients who have overuse injuries. So think about your patients who are doing prolonged PT sessions or prolonged ruck marches, things like that. This is a real big issue, especially if it occurs in high temperature settings, so in very hot climates. Because what happens is that when you're using your muscles over and over and over, you're using a lot of that ATP, that energy, right? And that energy or that muscle, whenever it's exposed to some type of high temperature environment, uses more of the ATP. So not only are you using that cell, not only is that cell trying to function by using energy to actually make it work, but then you throw in heat on top of it, and that's going to cause you to lose more of that ATP because it's not able to generate ATP as well in that heat setting. So patients who are working out vigorously in high heat settings, they're more at risk for this. But it doesn't necessarily just have to be, overuse of the muscle. It can just happen in very hot environments or very cold environments. Again, because that heat is going to cause that cell to use more ATP than normal. And when we lose ATP, if you guys remember from the first block, that we need that energy to help those sodium potassium pumps. And when we start losing those pumps, cells start to swell, and when they swell, they start to break down. They start to disintegrate because they're too swollen. For the cold environments, so cold, think about that. So when patients are exposed to really, really cold temperatures for a very long time, that's going to cause vasoconstriction. So we're decreasing the amount of blood going to that cell. And then on top of that, what happens to our bodies whenever we're trying to stay warm? We start to shiver, right? So our brain sends a signal to our muscles to start to shiver in order to kind of generate heat. But if we don't have enough blood flow going to the muscle cells already, and then we increase their activity by causing that shivering, which is its job is to generate heat, we're going to start causing issues with that energy production. So there's increased demand, but not enough ATP. So that can also cause injuries to our muscle cells, which can cause them to leak out. Now, one thing you got to worry about with rhabdo is something called compartment syndrome, and we'll talk about that in the next slide. But essentially, when the muscles they're in their own little compartments, right? That compartment is surrounded by something called fascia, and that fascia kind of keeps everything nice and neat. But that fascia doesn't allow the muscle to swell. It constricts that muscle. So when the pressure inside the compartment starts to increase, we start to cause ischemia. We start to cause decreased perfusion to that muscle, which can cause further damage and cause that muscle to start to die from that ischemia. Patients, typically when they present with rhabdo, they're going to have muscle pain. That's very characteristic. They're going to have pain in that muscle that's starting to become ischemic and starting to die. There will be swelling because as that muscle cell starts to break down, it's going to release its contents. It's going to cause inflammation, and so we're going to start seeing swelling in those limbs that are affected. Muscles, they have myoglobin. That's what helps kind of helps that muscle actually function by using that myoglobin. And when that myoglobin in the muscle starts to come out of it, it's going to go into our blood. And when it goes into the blood, it's going to get filtered out by the kidneys. And the problem with myoglobin is that myoglobin is toxic to those renal tubules. It's toxic to the tubules. And when it's in those tubules, it starts to cause damage to the kidney. And so one of the things we got to be careful about is that if we have an increased amount of myoglobin being released from the muscle that's going into the kidney, if it causes a lot of damage, it potentially could cause kidney failure. And so the way we treat this is by trying to really just kind of flush the kidneys out by giving patients large volumes of IV fluid. So we're trying to enhance that perfusion to push that myoglobin out of the kidney, because if it stays in the renal tubule, if it stays in the kidney, it can cause damage to that kidney and cause a need for dialysis if we're not able to, if the kidneys are damaged too far. Muscle cells, really all cells, have high potassium in them, so including muscle cells. So when those muscle cells start to break down, they start to release their potassium. And if we have an increased amount of potassium in the blood, then that's going to cause a lot of issues with our heart, because we need a certain concentration of potassium. And if it gets too high, then it can start to lead to arrhythmias or abnormal heart rhythm changes. And so that's something else we got to be careful about. Myoglobin, or muscle cells, they have creatine kinase. So if you guys remember, we kind of talked about it a little bit. They have a specific creatine kinase called CKMM that's specific to skeletal muscle. And that's one of the ways we can diagnose this. Is patient comes in, they have muscle pain, they have some type of exposure that led them to us think they have rhabdo. Well, then we can get a creatine kinase MM, right? That's that subtype of creatine kinase. And that's going to be typically really elevated, and that's going to lead us down that path that suspects somebody has rhabdo. Another lab you can do is a urinalysis. So the thing with the urine dipstick, we kind of talked about a little bit. The urine dipstick, essentially, what they do is they take this kind of it's essentially a dipstick, and they dip it in the urine. And that dipstick tells us a lot of things, but one of the things it can do is tell us if there's blood in the urine. But the urine dipstick, it's not really looking for blood. It's looking for that heme component that's in blood. And so there's also iron in myoglobin, and so it's going to pop positive for blood. Even though the patient's not bleeding, there's no actual blood in the urine. It's picking up that heme that's in the myoglobin, and so you can't have a positive urine dipstick. But whenever the lab sends it for urine microscopy, so when they actually look at it under the microscope, they're not going to see any red blood cells. So one of the key features is that they'll have a positive urine dipstick, but then when they do microscopy, there's no RBCs in it. All right, so compartment syndrome. So with this, like I told you guys, we have our muscles and they're wrapped in fascia, right? And there's different compartments for each muscle group. And so when we have an increased amount of pressure in those compartments, it's going to cause issues with perfusing those compartments, because that pressure is too high and blood can't perfuse into those muscles like they're supposed to. And so typically you'll see it either after rhabdo, or it can be caused by trauma, some type of trauma to typically it's going to happen in the extremities. Anything that's going to cause increased amount of pressure, like trauma or overuse of a muscle, can lead to compartment syndrome. And there's 5 features, the 5 Ps, and these are classically described with compartment syndrome. So the first thing you're going to see is pain. That should be pretty obvious. Patients are going to have pain, but the thing with this is that this pain is out of proportion. Meaning, they say somebody has compartment syndrome in their calf, right? They have compartment syndrome in their calf. When you go and you evaluate that calf and you push on it, well, it's going to be painful. But then when you try to dorsiflex that foot, when you try to put that calf on stretch, they're going to have a lot of pain with that, which is going to be abnormal. It's going to be more so than what you would suspect. So that's what that pain out of proportion is. And we're going to try to treat them with medications, but that pain is very, very hard to treat because that capsule is swelling. They may have paresthesias, especially as that swelling starts to increase and that pressure starts to increase, because there are also nerves in those compartments. And so when we push on those nerves, when we increase the pressure on those nerves, it's going to cause numbness and tingling. Over time, as that pressure starts to increase, again, we're causing issues with perfusion, and so anything past the point where the compression is occurring, you're going to start having cool skin and decreased color to the skin, and that's from that reduced blood flow because that pressure is so high. Over time, if this thing persists, the patients can develop paralysis because we're causing a lot of compression on those nerves, and so patients are not going to be able to move those parts of those muscles that they should because those nerves are being compressed. And then pulselessness is a late finding, so this is typically from just prolonged compartment syndrome that patients sat on or we didn't get to in time. And again, there's no perfusion going to extremity. So when you go and you check those pulses, whether it's typically it's the legs, and so the dorsalis pedis, posterior tibialis, those are very, very hard to appreciate because that pressure is so high. It's compressing on those blood vessels. It can also happen in the upper extremity, so the forearm. So when you check the radial pulse, you may not appreciate that, but that's typically a late finding. And when that happens, that risk, the risk of losing that limb is very, very high because this pressure has been ongoing for so long. So the way we kind of check for this is that we do something called intracompartmental pressure monitoring. So essentially, we are able to get this device and stick it into the muscle, stick it into the compartment, and then see how much that pressure is. And I'll show you a picture of this device here on the next slide. But what we want to make sure is that our diastolic pressure is greater than the compartmental pressure by at least 30 degrees of mercury. So if that pressure starts to narrow, that means that the intracompartmental pressure is becoming too high. When that pressure becomes too high, then that's going to represent a decreased amount of blood going to that muscle group. And so we are able to look at these pressures. So we check our diastolic pressure, we check the intracompartmental pressure, and then based off that value, we take the diastolic pressure and then we subtract from the intracompartmental pressure. And if that value is less than 30, that tells us that pressure is becoming too high. And what we're going to have to do is typically send them to ortho. And ortho, what they're going to do is go into that actual muscle and cut that fascia in order to open up that muscle and allow it to swell. So if we can open up that fascia, we can relieve that pressure. So this first picture over here, this is what you'll see with rhabdo. Again, you got that myoglobin being released into the blood. That's going to be filtered by the kidney, and then when it gets into the kidney, it's going to look like blood. It's going to be darker though, but when you actually do that microscopy of that sample, you're not going to see any red blood cells. You're also going to have the hyperkalemia. Don't really worry so much about what you'll see as far as EKG findings, and you'll get that next block or next semester in EKG. But just understand that high potassium is going to start causing some changes to the heart and the way the heart beats. With the compartment syndrome, again, you can see how over here, how each muscle group is surrounded by fascia. And when that pressure builds up, it's going to start pushing on those nerves, the blood vessels, which is going to decrease that perfusion to that muscle. And so the way we check for it is by putting in this device here, and this device actually tells us how much pressure is in that compartment. And then if that pressure starts to become too high, then we're going to send them over to ortho to do the fasciotomy. Here's an example of kind of what that looks like. So again, they're just going into that muscle, and they're releasing this fascia over here to try to let that muscle expand. Because if they don't, then that muscle can't swell, and then when it can't swell, that pressure is going to increase inside the compartment. All right, so neuromuscular disorders. So Duchenne's and myasthenia gravis. So we talked about Duchenne's a little bit during our first block of lectures. If you recall, this is that X-linked recessive disorder where typically the mom has the disorder, right, or not disorder, but the trait. And it's on that X chromosome, and so whenever she passes it to her children, if she gives it to her son, then the son's going to have this disorder because he only gets the X from the mom and gets a Y from the dad. If you recall too, this is a problem with a protein called dystrophin, and that dystrophin, its job is to help really stabilize the cell membrane of the muscle. When we don't have this dystrophin, that muscle cell can actually break down very easily. And really over time, as those muscle cells start to break down, we can't regenerate them. And so we get a lot of scarring and a lot of fibrous tissue that replaces it. Most of the time, you're going to see this, or you're going to start to pick it up as kids start to move about. So typically early childhood, between 3 to 5. And essentially what you're going to see is that they're going to start having issues with their strength and kind of how they walk and how they get up off the floor. So there's the most common muscles that are affected first are the muscles of the pelvic girdle and the thigh muscles. So think about your glutes and then those muscles of the like the adductor magnus. Don't really, I wouldn't put too much focus on the actual muscles themselves. Like I wouldn't try to memorize glute and all that kind of stuff. Just understand that this is a progressive disorder, and that's kind of the first place where this starts. Over time, most of the muscles are going to start getting damaged, and so it's going to progress. But those are kind of the first muscles that are initially impacted because we use them so much, right? This Gower sign, this is something that I would make sure you guys are aware of, because this is something that this is when you're interviewing your patients, when you're interviewing the parents, this is something that you want to ask their patients. You want to ask them. You want to ask, like, how are they getting up off the floor? Because people who have Duchenne's muscular dystrophy, they have this very classic Gower sign. Essentially, they have a hard time getting up off the floor because their muscles are so weak. And again, you got to think we use our thighs, we use our muscles in our glutes to help us stand up. And so as these muscles start to break down, they're going to have a hard time getting up from a seated or lying position. So instead of just kind of standing up like a normal person would, they have to use their hands to walk up their legs. And I'll show you kind of what that looks like in the next slide. But they're essentially using their upper extremities to push up off their legs to actually stand up erect. They're going to have waddling gait initially. Again, those muscles in the lower extremities are typically affected first, and then it's going to start to affect other muscles later on in life. And so by the time this kid is 10 or 12 years old, they're not going to be able to walk well, so they're going to need a wheelchair. You can do labs for these folks, and you're going to see that the creatine kinase is elevated. We don't really get into specifics on creatine kinase because, I mean, the MM subtype is going to be elevated, but also the MB, if you recall, that's for the heart. Don't really have to really know that, but just understand that the creatine kinase is going to be elevated as those muscle cells start to break down. We can do testing on our folks who have this. So we do a muscle biopsy, and we can see certain characteristics on the muscle biopsy that would tell us that this patient has this. More commonly, what they're going to be doing is genetic testing, because this is a inherited disorder. So most people know that there's a family history of this. Maybe it's possible if they're adopted they wouldn't know this, but so we can actually do genetic testing before the child is born. If you recall from the first block of lectures, we talked about amniocentesis and chorionic villus sampling. So those are things we can do before the child is born, just to kind of help the parent kind of know what they're up against, right, and how to prepare for a child who may have this disorder. The problem with this is that there's no cure, so this is going to progress. It's going to start to affect most of the muscles in the body, and really the thing that kills these folks is that when it starts to affect the diaphragm and the intercostal muscles that help us breathe, they're going to start developing severe respiratory complications, and so most of the time they're going to die early in their teens and their 20s. Now we can give medications to kind of help slow the muscle wasting process. So prednisone is a typical one that they'll give, and think about when cells are injured, right? When cells are injured, what happens? They have inflammation. Inflammation comes and it kind of helps along to try to get rid of that injured muscle. So if we give them steroids to decrease the inflammation, then we can slow the muscle wasting, because we're essentially stopping our immune system from coming out and breaking down that muscle further. So that's how steroids kind of help with decreasing that progression. But it's still going to happen. This is just going to slow that. And in physical therapy, we typically get these kids in physical therapy just to kind of help them, because they're going to have issues with walking and they're going to have issues with movement. And so PT can help them just kind of get about and show them kind of the ways to kind of live with this disorder. But it's not going to cure them, obviously. So here's that Gower sign, and again, I know this is an FYI slide, and so definitely there will be no pictures, but I would definitely understand the process of how this can look, how a patient may present with this. So they can't get off the floor because their muscles in their lower extremities are weak initially. And so for them to get up off the floor, they have to push themselves up, have to use their legs to push their body up, and eventually stand up erect. So very important to know that. All right, so myasthenia gravis. So this is an autoimmune disorder. It typically affects males and women, but the age ranges are kind of different for when the women get it versus when the males. So women get it typically when they're a little bit younger, 20 to 40, and men typically when they're 50 to 70. And the problem here is that so you have these antibodies that develop against what are called acetylcholine receptors, and if you guys remember back from anatomy probably, you remember that in order for a muscle to actually move, it has to get a signal from the nerve, right? And the way it gets that signal is through acetylcholine. So acetylcholine is released from the nerve, and then you have these receptors on the muscle that those acetylcholine neurotransmitters actually stimulate to tell that muscle to move. So the receptors are on the muscle, and then the acetylcholine is released from the nerve. When you make antibodies to those receptors, they're going to do a couple things. They're going to block, so they're actually going to sit on those receptors that are on the muscle. And so when acetylcholine is released, it's blocking it, right? So then if the receptor is blocked, it's not getting that signal from the nerve to actually move. And not only that, but when those antibodies attach to the receptors, they can actually activate the complement system, and so that complement system can actually destroy those receptors. And so if we have blockage of receptors and we have destruction of receptors, then the acetylcholine that our cells are making are not going to be causing stimulation of the receptors because they're blocked or destroyed, and so those muscles are not going to be moving, right? Or they're going to have a hard time moving. Now the thing with this is that those antibodies, they don't block all the receptors because you have a lot of receptors, and they don't destroy all the receptors. And so over time it could if we don't treat this, but what we'll see here is that these patients, they're going to have muscle weakness and fatigue as their day progresses, because the nerve can only make so much acetylcholine. And so if we block the receptors because we have the antibodies on them, and then over time if we destroy those receptors, the amount of acetylcholine that our nerves are making can still get on those receptors, but there's less of them. And then on top of that, as those nerves are using this, as they're sending out acetylcholine, and they're not making as much as the day progresses because they can only make so much. As these patients are using those muscles repetitively throughout the day, they're going to start becoming weaker and weaker as that day progresses. Now, when they wake up in the morning and the body has time to make acetylcholine again, well, then they're going to have typically pretty normal strength. But then again, as the day progresses and they're not making as much acetylcholine, they're going to start becoming weaker. But this is a progressive issue, and so initially that's kind of how it first starts off, and then as time goes on and these patients have this disorder for a very long time, then that weakness can definitely get a lot worse. Typically, it's going to affect it's going to be more noticeable in the muscles of the face and the eyes, because you got to think, we use our face, we use our eyes throughout the day, right? We're talking, we're looking, we're moving our eyes back and forth, and so we're using those muscles quite a bit. And so if we have a decreased amount of receptors, and then as the day progresses, we're not making as much acetylcholine, those muscles are going to start becoming weak. And so that's typically what you're going to see, or how patients are going to present. They're going to have ptosis, or they're going to have eyelid drooping. They may have double vision because it also affects the ocular muscles. And then their facial expressions are going to be bland because, again, they're not stimulating those muscles as the day progresses. So that's what that fast twitch, short exertion muscles mean. So think about the eyes, right? We're using them. They're moving very quickly to help us see, but they only have to go a short distance. There's not a big range of motion with our eyes, and so that's what that short exertion means. We can do labs for these folks. We can check for those antibodies, so acetylcholine receptor antibodies. And then the way we can test for this is by doing something called a acetylcholinesterase inhibitor challenge. So essentially, it's a medication that you give to your patient, and there's an enzyme that is normal, and its job is to break down acetylcholine. So we give this medication to stop that enzyme from breaking down the acetylcholine, which means we have more acetylcholine in that actual synapses before it starts to break down. So the idea behind this is that if we increase the amount of acetylcholine that's available by preventing the breakdown of it, we're able to flood the open receptors with the acetylcholine neurotransmitter, which means that they're going to be able to use those muscles, or they may have fatigue, right? And then we give this acetylcholinesterase inhibitor challenge, and so we're flooding those receptors with more acetylcholine, so now that weakness improves. So that's one way to kind of check for that. To actually treat this, we're actually going to give the acetylcholinesterase inhibitors. So there's pristagmine is an example. Again, you don't really need to know that. That's one example of a medication we can give. Again, the main focus there is just to increase the amount of acetylcholine by preventing the breakdown of it. There's no cure for this, but we can control this. We can give steroids, and those steroids will help reduce the amount of those antibodies that are being made that are actually attaching to the receptors and causing the breakdown of them. And there are also some other medications that are more targeted. So corticosteroids, they're kind of widespread. They stop inflammation, but at a high level. There are other medications you can give that kind of focus on kind of the main thing that's causing this. And you guys should learn about this when we talk about this in pharmacology. But that's just an example there. So here's a picture of what that looks like. So you can see, again, you got your nerve cell up here, and it's releasing that acetylcholine, and then you make these antibodies, and these antibodies block those receptors. Doesn't block all of them. What's not shown here is that complement destruction, but that typically occurs later on. But we have antibodies blocking the receptors, then the acetylcholine can't act on them. And when it can't act on them, it's going to cause a reduction in strength. And so as a result, your patients are going to have that ptosis. They're going to have facial drooping. They're not going to be able to use their muscles because they're not being activated because of that acetylcholine blockage. Over here, you got the acetylcholinesterase inhibitor challenge test, just kind of what that could look like or what that looks like. So normally, you got acetylcholinesterase, which its job is to help break down the acetylcholine. By stopping that enzyme, by giving those medications, we can increase the amount of acetylcholine in that region to allow the acetylcholine to actually act on the open receptors. Okay. All right. Any questions about that? Actions that we can experience, and then some type of neurodegenerative diseases, which there are several of them that can cause issues in our older patients and sometimes younger, depending on what we're talking about. So focusing on brain bleeds and intracranial hemorrhages. So the first one is the epidural hematoma. So here, this is where blood collects between the skull and the dura mater. So that kind of tough layer right under the skull. And most of the time, this happens from trauma, typically from trauma to the temporal parietal regions. And the reason behind this is because especially that temporal region, that bone there is very, very thin. And there's an artery called the middle meningeal artery that sits right under it. So when there's trauma to that area, there's a high likelihood that artery can be damaged and cut. And when it's cut, it's going to bleed, but it's going to bleed under the skull, above the dura. The thing with this one is that dura mater, if you guys remember, there are cranial sutures, right? And they're there initially to kind of help the skull form and kind of get past the birth canal when a child's being born. Then as a person gets older, those sutures they start to harden, right? But that dura mater actually anchors to those sutures. And so when bleeding occurs here, that blood is not going to pass those cranial sutures. It's gonna, because that mater is very, very tightly held there. And so when that happens, we get this very characteristic appearance on brain CT. It's got a biconvex or lens-shaped appearance. So it looks like a lens, right? Because that dura mater is anchored to the cranial suture, it's not going to be able to get past that. So what happens though is that as that bleeding continues, it's going to start pushing that dura away from the skull into the brain. So that pressure is going to start to increase. With this injury, these patients have this kind of the most common causes of viral meningitis are the enteroviruses. So think about Coxsackie and echovirus. These are typically GI viruses, but they also spread through the respiratory tract, so it can infect the upper respiratory system as well. Bacteria. So we typically break these down into age groups or typical patterns involving adults versus younger children and young adults versus kids. So adults, most of the time, we're thinking Streptococcus pneumoniae. For children and young adults, this is Neisseria meningitidis, and there's vaccines for this one. We can prevent this. This is actually it's very common for colleges to require kids to develop, not kids, but young adults, I guess, to get this vaccine before they go to college because of that risk is so high with these folks, because they're such in close proximity with one another. For neonates, so Group B strep, this can be found in the vaginal flora. It's typically found in the intestines, but sometimes bacteria can get in there, and once they get inside the vagina, they can colonize the vagina. And so if a mother has Group B strep in her vaginal canal and that child is being passed through the vaginal canal during birthing, then the child can develop Group B strep meningitis. And so this is one of the things we actually screen for before a mother delivers. And then if she's positive for this, we'll treat her for this to reduce that risk of it spreading to her child. When these patients have meningitis, they're going to have classic symptoms. They're going to have fever, headache, and as those meninges are irritated, they're going to start causing nausea, photophobia, and sometimes confusion. And it really just depends on was it viral, was it meningitis, and the severity of it. But they'll typically have fever and headache. Nuchal rigidity it's where those meninges, they're not only in the brain, right? They're also in our spinal cord. And when the meninges in the neck region are inflamed, and we put that neck on flexion, so we bring the neck forward and have the patient look down, that inflammation is going to cause pain because those meninges are also irritated. So they'll have nuchal rigidity, where they'll have a stiff neck essentially. There are a couple signs that we can do to help us figure out whether it's meningitis or not. One is called the Brzezinski sign. And this is where we have a patient lay down flat, right? They're laying down flat on their back. And then the PA, we flex their neck, and that irritation is going to cause pain in the actual spinal cord because those meninges are inside the spinal cord as well. And so by putting the neck on flexion, what the patient's going to do is they're going to flex their hips and knees to reduce that tension, because that spinal cord, obviously starts in their neck and goes all the way down to our lumbar region. And so by putting that neck on flexion and really tightening those meninges, we're trying to reduce, or the patient's trying to reduce that stretch. And so what they'll do is, again, they're going to flex their hips and knees to take that tension off. Kernick sign is where we have the patient again laying on their back. We take their hip, we flex it to 90 degrees, and then we try to extend their lower leg straight out. If this causes pain in the posterior thigh, it can also cause pain in the back, but it causes pain in the posterior thigh, or they resist us from actually straightening out their lower leg, that's a positive sign. So they have these symptoms of fever, headache. We do these Brzezinski sign, we do the Kernick sign, and if those are positive, again, that should lead us down a path to suspect maybe this is some type of meningitis. So here's what they look like. So Brzezinski's, patients laying flat on their back, flex the knee, or sorry, flex the neck, and then when they do that, the patient flexes their hips and their knees to reduce that tension on their inflamed meninges. For the Kernick sign, patients laying flat on the back, we take their hip, bring it up to 90 degrees, then we try to extend that lower leg straight out. And if that causes pain in the posterior thigh, or the patient resists us from doing that, that's a positive sign. All right, so meningitis. So I would definitely be able to tell the difference between what you would find on lumbar puncture. So to diagnose this, we're going to do a lumbar puncture. We're trying to collect CSF from that subarachnoid space because that's where that stuff is at, right? So we insert a needle into the spine and we try to pull CSF. If it's a viral meningitis, that fluid, the CSF, is going to be clear because although there are white blood cells, typically lymphocytes, there's not a lot of them in comparison to bacteria, at least. And so it's not going to be cloudy, it's going to be clear. Viruses, lymphocytes, their main job is to do a number of things, but they help us fight off viral infections. And so when we pull this CSF and we send it for a gram stain, because we don't know, right? We don't know whether it's bacterial or viral yet. We're going to send it for a gram stain to try to look for bacteria, but there's not going to be any bacteria and the viruses are not going to show up on gram stain because they're too small to be stained. What we are going to see is an increased amount of lymphocytes, and we can actually see that on gram stain. I'm not sure if you guys covered gram stain. I think we kind of talked about it, but essentially we just take the fluid and we stain it with different colors, if you will, and they depending on what cells there will show a different type of color. Lab should hopefully talk about this with you if they haven't already. So again, gram stain is going to be, or I'm sorry, clear fluid. Gram stain is just going to show lymphocytes, but there's not going to be any bacteria. Okay. We can also check for protein levels and glucose, and that's one of the things we want to make sure we're checking for. With viral meningitis, that protein level, is it going to be normal or it might be a little elevated? So normal or slightly elevated. It's not going to be dramatically elevated like bacterial. It's going to be, and that's because lymphocytes have proteins in them. It's an inflammatory process, so there's going to be inflammatory proteins. So think about the complement, right? Those are proteins. And so when we run this lab, we're going to have a little bit of elevated protein, or it could be normal. It just depends on the severity. The glucose is going to be normal. So we normally have glucose in our CSF. The viruses don't do anything to this glucose, right? And so that glucose level is going to be normal in the CSF. Now bacterial, this is different. The fluid is going to be cloudy because this creates a more dramatic inflammatory response. So we're going to have a ton of neutrophils and bacteria, so that's going to make that fluid more cloudy. There's more stuff in it, right? The protein level is going to be high because not only are the bacteria releasing their proteins and the white blood cells, but also the WBCs are releasing their proteins to try to fight off this bacteria. That glucose is going to be low because the bacteria is consuming the glucose in the CSF. So glucose is going to be low with these guys. Now, most of the time, we're going to be doing, the gram stain is going to give us like a quick answer. We're going to be able to pull the CSF out, send to the lab, and the lab within the hour will tell us, what's going on as far as, what kind of cells are seeing lymphocytes versus neutrophils, and if there's bacteria or not. But it's not going to tell us what type of bacteria this is. So we have to still send it off for a culture, and that culture doesn't come back quickly. It can take days for that culture to come back and tell us what's going on. But the gram stain will give us a kind of quick answer. That way we can try to treat it, based off the findings. But we do want to know what the bacteria is. So that's where that culture comes into play. But it's a slow test to come back. But you want to do them together. You want to order them both. Treatment-wise, so viral meningitis, again, usually our patients will get better as long as we're just supporting them. We don't necessarily need to give them we just got to make sure they're not getting worse, essentially. But we're going to admit them just to make sure, but again, most of the time, self-limited, they'll get better with time, and we're just monitoring them and just kind of step in when we need to, but they typically get better. With bacterial, we have to treat these folks with IV antibiotics, and we have to do it quickly. We want to do it after we do the lumbar puncture, but there's a caveat. If for whatever reason there's a delay in the lumbar puncture, if we, say, I don't know, you want to send the patient for imaging, or you can't get access because the lumbar punctures are not easy. They're kind of difficult to do. Actually, they're really, unless you do them a lot. I've done them a few times, and they're hard to do. If you have trouble getting the lumbar puncture, then we don't hold antibiotics. So we typically want to give antibiotics after the lumbar puncture, but if there's any problem with us getting that puncture, then we're gonna give it some straight away, because time is tissue. If we don't treat these quickly, the greater risk of this infection getting worse, and so we want to give them as soon as possible, but we don't want to delay it, right? We don't want to have any delay in it. And so if we can't do what we need to do, we're just going to give them antibiotics. You also don't want to hold antibiotics for lab results, so you don't want to hold antibiotics for the culture to come back, because that's going to be days, and so we want to treat this quickly. And then once we get the culture back, and once we identify, what pathogen is causing this bacterial pathogen, then we can kind of target the antibiotic to that pathogen. But in the meantime, we're going to just give them kind of a broad spectrum to kill a number of those pathogens. And then over time, we can change it if we need to. And these patients are going to be admitted. We're going to admit them because they're at a very, very high risk of decompensating. All right, rabies. So rabies is very, very deadly. Very, very, very deadly. I'm sure you guys know that. That rabies virus, it's only found in the neural tissues of those infected and the saliva. Now, most of the time, nobody's out there playing with neural tissue from a dead rabid animal. So most of the time, this is spread through being bitten by an animal that has rabies, because that saliva has the rabies. And once that, and dogs, coyotes, raccoons, bats, like essentially anything that's crawling on four legs can give you rabies, as long as it's a mammal, right? If you're bitten by an animal that has rabies, that rabies virus doesn't spread through the blood. It actually spreads through the nerves. And so you're bitten, the saliva has the rabies virus, it attaches to the peripheral nerves. And then from the peripheral nerves, it starts to make its way back up through those nerves to the spine, and then eventually the brain. And once it gets to the brain, you're a goner. Now, it's a slow process, so it doesn't happen quickly, but I will say it really depends on where you're bitten. If you're bitten anywhere close to the brain, not testable. Yeah, you're right. Not testable, but yeah, rabies is definitely here. If it happens anywhere close to the brain, so you get bit on your hand or your shoulder, then those symptoms are going to present a lot faster than if you were bitten like on your foot. But still, no matter if you're bitten anywhere, eventually that rabies virus is going to make its way back up the spine into your brain. So initially, when patients have rabies, they're going to just have these generalized flu-like illnesses. They're going to feel like they have the flu. They'll feel feverish, body aches, headaches. But then as that brain starts to become more infected, right? And a brain infection is just called encephalitis. So as there's inflammation of the brain, these patients are going to start having other issues. They're going to feel agitated, and they're going to feel delirious. And this hydrophobia is actually kind of pathognomonic for rabies. So what happens here is that the infection goes to the brainstem, right? And it eventually makes its way up to the brain. In the brainstem, that controls a number of our vital functions, right? But one of the things it controls is our ability to swallow. And so whenever somebody has rabies and you give them water, it causes a severe spasm of the muscles involved with swallowing, that these patients, when they're trying to drink, it's very, very, very painful. But not only that, though, when they hear water or when they see water, it causes a triggering of those muscles that help us swallow, those pharyngeal muscles. And so these patients are afraid of water. So they're hydrophobic, right? When they hear water, when they see water, if they try to drink water, it causes very, very, very severe pain. And so it's called hydrophobia. Now, with time, these patients, as that brain starts to become infected and inflamed, they're going to develop a coma, and eventually it's going to lead to death. And I think you said there were 18 cases of rabies in Bexar. Wow, that's a lot. Most of the time when you have rabies, you're going to die. Like if you don't get treatment right away, and you don't have certain things beforehand, you're going to die if you get rabies. There have been cases of people surviving rabies, but that's because they were able to get treatment right away, and really most of them had the rabies vaccine, because there's a rabies vaccine for people too, but 99% of the time you're going to die if you get rabies. And so if somebody's been exposed to rabies, if somebody was bitten by an animal and we don't know whether or not this animal had rabies, well, we're going to do a few different things. You need to tell your patients this too, especially if you're out somewhere where there's rabid animals, like a deployed setting. If they get bitten, they have to clean that wound, and they have to clean the heck out of it. Soap and water, just clean it, flush it, try to get that area clean. On top of that, we're going to give them something called post-exposure rabies immunoglobulin. So essentially, it's just antibodies against the rabies virus. And most of the time, we inject this immunoglobulin around the site where they were bitten. So we're trying to get those antibodies to that site so it can kill that rabies virus before it starts to spread up the nerves. But not only that, we're going to give them the vaccine too, because we want to give them the antibodies and we want to make sure that they're making antibodies. So we'll give them the vaccine. And it says, even if unsure if bite occurred, this is true. I had a patient one time who came to see me because when she woke up, there was a bat in her room. This was in California. And she asked me, do I need to get, do I got to do anything? I was like, were you bitten? She said she didn't know. And bat bites sometimes will bite you, and they're so small that you may not know that you were bitten. And so for her, we had to send her, because we didn't have this stuff in our clinic, we sent her to the ER, or I sent her to the ER, and they ended up giving her the immunoglobulin and the vaccine. Now, obviously, they couldn't give it to her around the bite because we couldn't tell if she was bitten, but they still gave it to her, and she was fine. But bottom line is, once you start developing signs of rabies, there's no effective treatment, and these patients most likely are going to die. So, all right. So autoimmune and neurodegenerative diseases. Okay. So multiple sclerosis. This is a problem. It's an autoimmune issue where our immune cells start to destroy the myelin that's around nerve cells, that are around the axons of nerves. And those axons, they help propagate signals, right? They help us send signals to other parts of our body very, very quickly. Without that myelin and without those axons, then our nerves can't signal, to parts of our, sensation or touch or, movement. We need those myelin, and we need those axons for that signal to actually make it to where it needs to make it to. When we destroy the myelin, the signal is a lot slower, and then eventually, because that myelin helps that axon live, right? It kind of provides nutrients to that axon. So when we destroy the myelin, we can also destroy that axon. So we're taking away the ability for that cell to signal to other parts of the body. Most of the time, this is going to occur in younger women between 25 to 45, and I've definitely seen it in mostly women actually when I've diagnosed it. The thing with this is that this condition causes what are called recurrent episodes of exacerbation or remission, meaning patients will have symptoms. And I'll talk about symptoms here in a second. They'll have symptoms, and then the body will, because the myelin is being destroyed, and then the body kind of calms down, and they go through this period where they're asymptomatic, and then they get symptoms again, maybe a month, maybe a year later. So it's this kind of recurrent episodes where they have symptoms of multiple sclerosis, they get better, and then it comes back, right? So it's a recurrent episode, and mostly affects your sensory and motor neurons, right? Sensory symptoms, so loss of touch. So essentially think about numbness, right? Patients, they may not be able to feel things when they're holding a pen or a pencil. They may not be able to really appreciate that they're holding that because we're not sending those signals to those nerves that tell us what we're touching because they're being destroyed. They may also have tingling because, again, those are as we're damaging those nerves, we're going to get numbness and tingling. It can affect the optic nerve because the optic nerve also has myelin around it. And so patients can develop blurred vision. They can also develop vision loss, right? It just depends on the severity of how much that nerve is being damaged from from the autoimmune attack. Motor symptoms, muscle weakness, unsteady gait. I mean, again, we send signals, our nerves send signals to our muscles to move. And so if we're destroying their ability to do that, they're going to have weakness. They're going to have difficulty standing or keeping their balance. And it says here, symptoms often seem unrelated. This is true. This is your patient who's going to come in. And when you get to neurology, it probably will make more sense. But when we think about nerve issues, we think about regions and we think about certain symptoms associated with that region. With these folks, because it's attacking multiple nerves, somebody may come in and they have, I don't know, weakness in their foot, but they also have numbness and tingling around their face, and they have blurred vision, right? Like, it doesn't fit a typical nerve pathology. It's kind of everywhere. And so when a patient comes in and they have this kind of generalized nerve-like symptoms, you got to think multiple sclerosis because that can present that way. How do we diagnose this? So we can diagnose this just based off symptoms. Like, there's no special tests we have to do. However, we're going to do an MRI because the MRI is going to give us a lot of information. And when I say MRI, we're typically doing an MRI of the brain and the spinal cord, depending on where the issue's at. Because with the MRI, we can actually see where that demyelination is actually occurring. Because on the MRI, it's going to show up as what are called white matter lesions. Because the white matter of our nerve, of our brain, that's where these axons are at. So because they're being damaged, we're going to see these lesions in the white matter of our brain or spinal cord. The spinal cord also has white matter, so that's why they're called white matter lesions. And most patients are going to have this, and so this is going to help us strongly. This is going to strongly help us support the diagnosis when we start seeing this kind of stuff. We can't do a CT because CT is not sensitive enough to actually pick this up. Treatment, no cure. There's no cure for this, but we can give steroids to help manage these flares, especially when they're having these exacerbations. There are other medications we can give that are more targeted towards stopping this. But just for you guys, just know that steroids can help manage a flare whenever a patient is having a flare of this. Unpredictable progression. Most of the time we don't know how far this is gonna, how bad this is gonna get. We try to treat the symptoms. We try to reduce the body's ability to attack itself. But typically after 20 or 30 years, these patients are going to just kind of have permanent worsening symptoms. And so the sooner we can get them treated, the sooner we can stop their body from attacking itself, the better off they'll be. But we can't cure this. There's no medication to actually stop this from happening. We just kind of slow the progression. So here's what this looks like. So myelin is typically, or it's around the axon. As we start to destroy that myelin, that signal is no longer moving fast down that axon. But what's not here is that axon is eventually destroyed as well. And so it's a kind of a twofold attack. You destroy the myelin and then eventually you destroy that axon. Here's an MRI of the brain that shows those white matter lesions. They're not called white matter lesions because they're white. It's just because they're occurring in the white matter of our brain where those axons are at, or the spinal cord as well. All right, Alzheimer's. So with Alzheimer's, this is going to cause dementia. And dementia just means these patients have a very, they have a problem with their memory, essentially. And then as it gets worse, it causes a lot of other issues. But so with Alzheimer's, the brain cortex, which has the actual neuron bodies, actual cells of our brain, it's in the cortex, right? It's in the outer part of our brain. What happens here is that there are some individuals who develop these things called amyloid plaques. These amyloid plaques, there's a precursor to them called amyloid proteins. And these proteins are actually in the cell membrane of the neuron. And then they actually help the neuron grow. That's what their job is. But as that neuron is growing, those proteins are broken down and recycled. But for some individuals, those proteins are not recycled. And when they're broken down, they actually can get in the way of cell-to-cell communication. They get outside of the cell. They're no longer in the cell membrane, and they start building up in these little plaques. And I'll show you a picture here in a second. And so when these plaques are in between cells, cells can no longer signal. They can't talk to each other because there's a blockage in between them. Not only that, these amyloid plaques, they're toxic to the cell, and they don't know how this happens, but what they think is that when these plaques develop, they can cause issues within the cell where you get these neurofibrillary tangles. And these tangles, there are proteins called tau proteins, and their job is to kind of help. There's something called a cytoskeleton in the neuron, and their job is to help make that cytoskeleton strong, because that cytoskeleton is how cells pass nutrients back and forth inside of itself. When you have these amyloid plaques that are causing these tangles to develop inside of the cell, the cytoskeleton starts to break down, nutrient system being passed back and forth within the cell. And so what that can do is lead to apoptosis of the cell, which is going to lead to cell loss, so cell death. So these plaques and these neurofibrillary tangles, both of them contribute to cell loss and cell death of the neuron. Let's see. This is typically going to occur around age 70, and this may initially show up as just kind of being a little forgetful, like you forget where you placed your keys or why you walked into a room. But as those neurons start to die and you start to lose more of them, then this is going to show up as worsening memory loss. So that's what dementia is. It's just a loss of memory. But not only do you forget, why you walk into a room, but you forget people, or you forget how to get home, or you forget faces. And so, or you forget how to do certain things that you used to be able to do on your own. And so by these neurons dying, these patients are going to develop dementia, which is going to put a lot of pressure on their caretakers, because this person can no longer care for themselves. There's something called the apolipoprotein E4. So apolipoprotein, it's strongly associated, the E4 version is strongly associated with Alzheimer's. And you get one from your parent, you get one of these genes from your parent, and from your mom, one from your dad, right? There's different variants of this protein, of this apolipoprotein. And the E4 variant, if you get one from your mom and one from your dad, you're at a greater risk of developing Alzheimer's. It doesn't mean you'll get it, but they've just seen that people who have Alzheimer's, about 50% of them have this gene variant. So it's just one of those things that increases your risk if you inherit this gene from your parents. We diagnose this clinically because we can't go and we can't do a brain biopsy on somebody. And so essentially we try to rule out other causes of dementia. And then once we rule out those other causes, then we say, hey, this person probably has Alzheimer's, and then we treat them as such. Let's see, sundowning. So sundowning, this is a behavior associated with Alzheimer's, or as the day progresses and as the sun starts to go down, these patients start to become more irritable and more restless. And the thought process is that Alzheimer's affects the part of the brain that controls our circadian rhythm. And so when we start to destroy that region, patients have a hard time kind of deciphering time of day, right? Not only are they confused or not only do they have problems with their memory, but now they're not getting the proper signal from that region that controls their circadian rhythm. So these patients are very, very irritable and restless as it starts to become nighttime. So that's a classic kind of a symptom of a patient who has Alzheimer's. As symptoms progress, we're destroying a lot of that brain cortex. Like I told you, they're going to have problems with other issues. They're going to have problems with taking care of themselves, and so this puts a lot of stress on caretakers. There's no cure for this. We can give meds to slow the progression and ease the symptoms, but it's not going to cure them. Some examples of some meds down under that, you don't have to memorize those meds or anything like that. Just what I really want you guys to understand, that we can't cure this. We can try to help by giving them medications, but this is going to progress over time. Now, this is not going to kill them per se, right? The Alzheimer's is not going to cause them to die or anything like that, but it's the inability to take care of yourself. It's the inability to go out and do things or where you're at an increased risk of developing maybe a secondary infection or maybe some type of injury while you're at home, maybe getting lost, right? And so the disease itself doesn't kill you, but kind of the complications of it potentially could. So here's what I was talking about. You get these amyloid plaques that develop, and it inhibits that signal. So it inhibits cells from talking to each other. So if you have these plaques that are in the way of cell-to-cell communication, well, now if a cell can't talk to another cell, then it can't send out a message to the rest of the body. But not only that, these plaques are thought to contribute to the development of these neurofibrillary tangles. So here's what I was talking about. These microtubules are what make your cytoskeleton, and their job is to help kind of send nutrients to other parts of the cell. And you have these proteins called tau proteins, and their job is to make sure that microtubule is strong, right? They kind of reinforce that microtubule. When these tau proteins start to build up and come away from those microtubules, they build up inside of the cell, but then these microtubules break down, and so cells can't send nutrients within itself. And so the combination of the breakdown of these microtubules, because these neurofibrillary tangles are developing on top of the beta amyloid plaques, are going to cause that cell to undergo programmed cell death or apoptosis. And when you do imaging of the brain up top, you can see how that cortex is starting to break down. So normal healthy brain, a lot of cells in the cortex, so it looks normal. As those cells start to die, that brain is going to atrophy, and so you start to see a thinning of that cortex. All right, Parkinson's disease. So when it comes to Parkinson's, I want you guys to kind of understand this, right? I don't think this is too important to really understand Parkinson's, but it may help. We have two systems that help control our movement. We have our pyramidal system and the extrapyramidal system. When the brain sends a signal to our body to do something, like our muscles, it follows this pyramidal system. And it helps control, we want to pick up a pencil, like our brain sends a signal to our hand to say, pick up this pencil, and it goes down this special track. The extrapyramidal system helps control that, though. So it controls kind of the smoothness of that movement, the coordination, it controls muscle tone, but we don't control that, right? Like, we're not telling our hand to go to this level of degree and slowly pick up this pencil at this angle, right? This is all involuntary, but that extrapyramidal system controls that voluntary movement. So when we lose that ability to really control that voluntary movement, and that's because there are these cells in what's called the substantia nigra that make dopamine. And dopamine is what's responsible for helping with those smooth movements. When we lose those cells, we don't make dopamine. And so when we lose dopamine, we can no longer really control those voluntary movements. So when they do a biopsy of people who have Parkinson's, they can see what are called Lewy bodies. These are abnormal proteins that develop in the substantia nigra, and they're toxic to the cell. They cause cell death, which is why they don't make dopamine anymore. And when we lose dopamine, then we lose that ability to control those motions in a way that's smooth, really. This is typically going to show up in our older folks, although there are kind of variants that can happen in earlier ages, like Michael J. Fox. He had it. He had a different variant, but still has Parkinson's. The clinical features. So these clinical features, they're classic for Parkinson's. I would definitely know kind of what these look like. So these patients can have a resting tremor of their hand or their arm. So it's called pill rolling. Essentially what that means is that when they're at rest, they have this position where, imagine if you had a pill between your thumb and your finger, right? And you're rolling it back and forth. It looks like that. That's what a pill rolling tremor looks like. This is classic for Parkinson's. When they move, when they have some type of purposeful movements, or they're going to go scratch their nose or something like that, the tremor will go away, but then when they're at rest again, it's going to come back. Because we're losing that ability to control kind of those fine motions that we don't normally think about, our patients are going to have what's called a mask facies, where they lose their ability to make facial expressions. They're going to have slow walking. So they typically walk with a shuffle, so they don't walk with a normal gait. They're kind of shuffling forward. And their movements are going to be very, very slow, because that dopamine kind of helps control the speed at which we move without thinking about it. And so these patients have a slow movement, especially when they're walking. Cogwheel rigidity. So think about like those old time, I don't know what's a good way to explain this. It's like a clock, right? And it has those cogwheels, and it kind of moves very slowly up and down, or moves very slowly, as it's going around that cogwheel. These folks are going to kind of, it's hard to kind of explain this without showing you guys, but think about your elbow, and you go and you flex your elbow. Normally you can do that in a nice smooth motion. With these guys, when they're trying to flex that elbow, it's going to like start, stop, start, stop, start, stop. So it's kind of going up very, very slowly, kind of like a lever where it just gets stuck, and then it goes, then it moves, then it gets stuck, and then it moves. So that's what cogwheel rigidity is. There's no cure for this. Over time, this can affect other parts of the brain. So these patients can also develop dementia. We try to give them dopamine, and so the meds we give them are levodopa and carbidopa, and we give it together, because if we give dopamine to somebody, our body's going to break it down. Before it gets into the blood, or before it gets into the brain, our body will break it down as it's being metabolized. Levodopa is a precursor that is able to get into the brain, but then the carbidopa prevents the breakdown of levodopa while it's trying to get to the brain. So we give them both. And if we give that, we can reduce some of those symptoms, but it's not going to cure them. They're still going to have this issue. So here's a picture of Parkinson's, so Lewy bodies, what they can look like, the portion of the brain that's affected, people who have it, obviously famous people like Muhammad Ali, and then typical characteristics of somebody with Parkinson's. All right, Huntington's disease. So this is a problem due to components of the basal ganglia. So the caudate nucleus and the putamen. The main thing I want you guys to be aware here is that these areas of the brain, they normally send signals to our body to prevent excess motion. That's what their job is. This is an inherited disorder, so this is actually an autosomal dominant issue where somebody has this gene and it passes to you, you're going to get this. When we lose that part of the body that helps control excess motion, we no longer have that regulator. And so these people have a movement disorder, and it typically affects that part of the basal ganglia first, but then over time it's going to affect other aspects of the brain. But that movement issue is due to the basal ganglia being affected. When people have this, they can't control their movements, so they have these involuntary movements, these gyrating movements. Looks like they're dancing. That's why it's called coriform. You see that picture down on the right hand side where the guy's sitting in the chair. They have these kind of circular movements. So they're moving around the central axis, where they're just kind of they have a circular type movements of their extremities, of their legs. Their face may have, they may be grimacing. Their tongue may be sticking out when it's not supposed to. They can't control this. There's no control of this. We can't cure this as well. We can give medications to help with the symptoms, but most patients die from this issue, either by hurting themselves on accident or sometimes taking their own life, right? So this is one of those issues where it's just a movement disorder where they have no control over it. All right, last one, ALS, so amyotrophic lateral sclerosis. So Lou Gehrig's disease is another name for this. So with this one, it's a muscle wasting disease, but the problem is not at the muscle. The problem is that the body starts attacking the upper and motor neurons. So the upper motor neurons tell our lower motor neurons to do things, right? And then those lower motor neurons tell our muscles to move. When we take out those motor neurons, we no longer innervate those muscles. And so when we no longer innervate those muscles, they're going to start to atrophy. And they're not going to work anymore because they're not getting signal anymore. So that's why it's a muscle wasting disease, not because the muscle is affected, but because those neurons are affected. The terrible thing about this is that essentially these patients can no longer move, right, as time goes on, but their cognition and their intellect stays normal. So they're essentially trapped in their body. They can think normally, they can talk normally, they can reason normally, but they can't move their body. Most of the time this happens in middle age and older folks, but look at Stephen Hawking down below. He got it when he was 21. He died when he was 76. So he definitely, I don't know if that's lucky or not, but he was one of those rare exceptions where it happened younger and he lived longer, because most of the time people have this, they're going to die within a few years. My last base, my technician, his father had this, and he died within a couple of years. So it really depends on, you know, how good of care you can receive. Most of the time, this is going to start off in the upper extremities. So patients will have these fasciculations of their hands, this kind of tremors of their hands, or not tremors, but just kind of twitching of their hands that doesn't move it. And then over time, this is going to start to affect all your muscles, your skeletal muscles, that is, and they're going to develop this rapid paralysis. And so they're not going to be able to swallow or speak. They're not going to be able to breathe, right? And so Stephen Hawking, he had he used a ventilator, so he was able to breathe on with that. But if you take out the diaphragm, you take out those muscles that help you breathe, well, you're not going to be able to breathe, and so that's typically how these folks die. Again, no cure for this. You can give meds to slow the disease process, but this is going to progress, and patients are eventually going to die from this. All right, that is it. Any questions for me at all? Positive animal rabies case prompts community. Yeah, I heard about that. It was like a skunk or something. I appreciate you guys. Yeah, thank you guys. So I'll work with your class leader on coming up with a time to come meet with you guys. Want to give you time. Want to give you guys. Appreciate you guys. Thank you so much. I want to give you guys time to prepare for your other class. Lose consciousness, right? They'll get stunned. They're going to have loss of consciousness. But the thing with these is that when they regain consciousness, they're gonna be alert. That's what lucid means. They're gonna have a lucid interval where they feel normal, they're acting normal, they're talking normal. But then as that brain bleed starts to increase that pressure in the brain, the patients are going to start to develop signs of increased intracranial pressure. So they're going to have a rapid headache, they're going to have nausea, vomiting, confusion, vision changes. And again, this is typically happening within minutes, because that brain bleed is, because think about arterial bleeding, right? That pressure is high. And so as that bleeding starts to increase from that high pressure, it's going to typically happen within a few minutes. It can be hours depending on how severe the bleed is, but again, but I want you guys to think of it as a quick process, essentially. The way they treat this is by doing surgery. So typically what they'll do is a craniotomy, where they'll take a portion of the skull out to actually remove the hematoma and relieve that pressure that's building up. All right, so subdural hematomas, these are another type of brain bleed, but different, right? So here, the bleeding actually occurs between the dura and the arachnoid mater. So we're kind of going down a little bit deeper. Thing with this is that these bleeds do cross suture lines. They do cross because it's under the dura, but above the arachnoid. And so it's able to bypass those sutures because those sutures, because that dura mater is attached to the sutures, but this is under the dura mater, and so that's why it can go past that point. And so typically the way you'll see this is by doing a head imaging, a CT of the brain, and it's going to have this crescent appearance because it's passing those suture points. And so think about, it kind of looks like a sickle cell, right? Most of the time when these happen, these are due to rapid acceleration and deceleration injuries. So think about your patients who are in a car wreck and they have whiplash, right? That brain moves forward, it gets stopped by by the seatbelt. Your body gets stopped by the seatbelt, but that brain keeps moving forward. And then as your head whips backwards, that brain goes backwards and hits the back of your skull. And between the dura and the arachnoid, you have these small bridging veins. You have these small veins. And so when that So when that shearing force happens, when you have this forward motion of the brain and it stops suddenly and then it goes backward suddenly and it stops suddenly, then those small veins can tear. It can happen too when patients fall. Most of the time, it's going to be your elderly folks. When they fall, they hit their head. Again, it's the same kind of concept. You're falling, the brain's moving forward. Your head gets stopped by whatever you fall on, but that brain keeps moving, and so that shearing force as well can start tearing those bridging veins. But think about veins, right? They're low pressure systems, and so these bleed slower. So most of the time, people have this issue because it's a slower bleed. That pressure is going to build up slower, and it really depends on how severe the bleeding is. But it can take hours, days, or even weeks, right? So this can even present patient may have hurt their head a week ago or 2 weeks ago, but it's barely presenting. It just depends on how many of those vessels were damaged. But it's still going to cause very similar symptoms as that pressure starts to increase, of increasing intracranial pressure. They're going to have a headache that's getting worse. They're going to feel drowsy, confused, irritable, and so. But it's typically a more gradual onset. It's not as quick as the epidural hematomas. Most of the time, we're going to be doing surgery for these folks as well to relieve that pressure. So same thing, craniotomy, just to kind of open up, remove that hematoma if we can, and then open up the cranial vault because that thing is enclosed. And so if we don't open up a release valve somehow, then that pressure is going to start to increase and cause a lot of issues. Here's an example of an autopsy that was done on somebody who had subdural hematoma. So you see that dura, that kind of gray fibrous looking tissue on top of the brain that's supposed to be there. When you pull that thing back, you can see that there was bleeding under it. And so that's what that looks like. All right, subarachnoid hemorrhages. So these are kind of, again, going a little bit deeper. The bleeding here is between the arachnoid and the pia mater. So between the arachnoid and pia mater. And this is typically arterial, right? So this is, again, more of a high pressure system. This can happen several different ways. You can have trauma, which, if you have significant trauma to the head, they can tear those vessels between that region. And so that's one way it can happen. Or, and more commonly, what you're going to have are these vascular abnormalities. And so if you recall last block, we talked about those saccular, those berry aneurysms that happen in that circle of Willis. This is the most common cause of subarachnoid hemorrhages. And remember, patients may not know they have this, and then all of a sudden this thing ruptures, and now they're having the very, very severe headache, and I'll talk about that here in a sec. But one thing you have to be aware of with these vascular abnormalities is that there's something where if the vessel leaks a little bit, or there's some type of issue where that vessel is leaking a little bit, the patient may actually present, or they may say later on that they had a headache before the actual rupture, because that blood is irritating in that subarachnoid space. So if there's a little bit of bleeding going on that bleeds and it stops, that blood is still irritating, and so that still can cause a headache. And so your patient may say, "Hey, I had a headache a couple of days before this actually happened," and so that represents, it's called actually a sentinel bleed. So it's kind of one of the early warning signs, if you will, that this could happen. The arterial venous malformations, so those are called AV malformations. With these are people who are born with these, and essentially what happens is that typically between the artery and the vein, you have capillaries. With these guys, you don't have those capillaries, and so the high pressure of the artery can actually go into that vein, and the vein is not built for high pressure, right? It's not as thick as the arteries. So as that high pressure from the artery goes into the vein, it can actually start to dilate it and cause it to break down and actually cause it to bleed. So that's one way it can happen as well, as those AV malformations. With these folks, with these guys, they're gonna have a very, very severe headache. And the thing I want you guys to understand, or make sure you guys are aware of, is that this headache comes on suddenly. It comes on suddenly. So make sure you write that down. It comes on very sudden. And they're often described as a thunderclap headache because they were just sitting there, or they were in line somewhere, or they were doing something where They were just kind of going about their day, and then all of a sudden they developed a severe headache. So that's not normal. People typically, when they have headaches, it kind of typically comes on gradual, and then it gets worse. These folks, it's a sudden headache. They often, it's not in here, but they often describe it as the worst headache of their life. So I'm sure you guys have heard of that term before. So those are things you don't ever want to hear with your patients, that I have a headache and it came on suddenly and it's the worst headache I've ever had in my life. When you hear those two things, you got to think subarachnoid hemorrhage, because that's how they classically present. When that as that bleeding starts to occur in that space, it's going to increase the pressure. It's going to irritate those meninges, and when that pressure starts to increase, when we increase the pressure in our brain and we don't do anything to relieve it, then what's going to happen? Blood flowing into it is going to be hard for blood to flow into it because that pressure is too high. So people can develop brain ischemia. And then what can actually happen is that pressure can start pushing down into lower pressure systems. And so it can actually push that brainstem deeper down into a place where it doesn't belong. And so when it gets there, it's going to compress that brainstem, and that brainstem is what essentially keeps us alive. It controls our breathing, our heart rate, controls a lot of things. So when we compress that brainstem, that's another way how people can pass from this. The way we treat these, like I said, most of the time they're due to subarachnoid hemorrhages they're due to the saccular aneurysms. And so if we identify the aneurysm, we repair it. And we're really just trying to make sure also that pressure doesn't increase too much, because if it does, then we're going to cause ischemia to the brain, which is going to eventually lead to necrosis of a lot of brain cells and death. So here's an example of, again, those saccular aneurysms, kind of where they could form. And then another example of the AV malformations. Typically you have capillaries, but in certain regions you don't. So that higher pressure from the artery going to the veins can cause that brain to become damaged and cause it to bleed. But again, the thing you need to be aware of is that these are going to come on suddenly. It's not something that happens gradually. It's a sudden severe headache. And here's kind of putting them all together, what they can look like. So the epidural hematoma, that's that biconvex shape. So it looks like a lens. The subdural is going to be that crescent shape because it's passing those suture lines. And then the subarachnoid, this is more diffuse bleeding following those contours of the brain because it's happening in the subarachnoid space. And so there's nothing kind of holding that back. So it's going to kind of look like it's bleeding everywhere in the brain. And our job is to find out where that bleeding is and try to stop it. Or not our job, but neurosurgery's job. Our job is to identify it and get them over to neurosurgery. All right, so cerebrovascular diseases. So talking about strokes. So we talk about strokes, right? Cerebrovascular accidents, CVAs. There's two different types of strokes. We have ischemic strokes and we have hemorrhagic strokes. Ischemic strokes are by far the most common type of strokes that we're going to see. And this is due to a decrease in blood flow to the brain, leading to ischemia and possible infarction. The most common causes are either a thrombus or an embolism. So a thrombus, you remember back from last block, we have some type of plaque that builds up in our arteries, and then that plaque ruptures, and then the body's going to come and try our platelets are going to come and start to attach to that plaque because that thing is thrombogenic. And when those platelets start to attach to that plaque, it's going to block the blood flowing past that point, and so anything past that blockage is going to become ischemic and is going to die. An embolism is where a clot travels from somewhere else, right? And we think about, when we talked about AFib a little bit, how if the heart's not moving like it's supposed to, it can lead to stasis, and so it can lead to clot development. And then if that clot breaks and goes to the carotid arteries and up into the brain, well, eventually it's going to come to a point to where it's too big, right? It can't get past the small artery, so that's going to lead to a blockage past that point. It can also happen in the carotid arteries, so that's why we check for bruits whenever we're listening to carotid arteries, because if there's a bruit, that tells us that there's some type of turbulent blood flow there. Typically represents plaque, and if that plaque ruptures, and that plaque actually, instead of causing a thrombus, or maybe it causes a small thrombus, if it breaks if it leaves that area and goes up to the brain, then it can also block blood vessels in the brain and then lead to ischemia and a stroke. That's more common is that ischemic stroke. Now, hemorrhagic stroke is another cause of this, right? And these are typically due to ruptured aneurysms and AV malformations. So the subarachnoid hemorrhage is a type of hemorrhagic stroke. So if we cause bleeding in the brain, then typically what's going to happen is that bleeding is going to increase that pressure. And then if we increase that pressure, we're going to cause ischemia to a number of brain cells. Clinical features. So when you have a stroke, either ischemic or hemorrhagic, you're going to have neurological deficits because our brain tells our muscles what to do. It tells us what to feel, right? And so if it really depends on what part of the brain is affected because different regions of the brain control different things. So you got to take that with a grain of salt. With these patients, they may have weakness, they may have paralysis, depending on what part of the brain is affected. Typically, it's only one side of the brain, right? So you're going to only have, so it's only going to be one side of the body that has this weakness. So it could be upper, lower, but it's unilateral. It's not, you're not having both arms that become weak or paralyzed. It's one side because it's happening on one side of the brain. Also, facial involvement, it can cause issues with movement of your face. That's why we check facial movements during a cranial nerve exam to see how the face is moving. But again, it's typically unilateral. If it affects another part of the brain, they could have difficulty speaking, not only because of facial involvement, but also too if it impacts that part that tells us how to speak or understand, then we could have trouble with actually talking. Hemorrhagic strokes, they may present differently than ischemic strokes. So ischemic strokes are typically associated with either weakness or difficulty speaking. The hemorrhagic stroke may have the weakness and the difficulty speaking, but it also may present with those other signs that are associated with subarachnoid hemorrhages, like a headache, pain, right? And so they may present just a little bit differently, but the best way we're going to be able to identify this and make sure that to try to determine whether this is a ischemic stroke or hemorrhagic stroke is we're going to send them over to get a CT of their head. And really the idea behind a CT is just to try to help us see, is this due to bleeding or is this due to ischemia? Because that CT, if it's due to bleeding, you're going to see this white appearance in the brain. If you don't see the white, then that tells us it's ischemic. Because if it's ischemic, then we can give medications called fibrinolytics, which can help break down that clot. But if it's hemorrhagic, we don't want to give fibrinolytics because we want that thing to clot. And so if we give fibrinolytics, then we're going to make this a lot worse. But no matter if it's ischemic or if it's hemorrhagic, we're going to get them over to a stroke center, a place that actually specializes in treating these strokes, because that's what they're definitely going to need a high level of care following the stroke. These transient ischemic attacks, so TIAs, are mini strokes. So patients can have strokes. These are typically ischemic strokes where this clot blocks that blood flow, but our body has a way of breaking down clots. And so if this happens where we develop this clot in the blood vessel and then our body quickly breaks it down, this is not going to cause infarction. And so when we do brain imaging, typically an MRI, we're not going to see infarction. And these symptoms, they typically resolve within minutes, most of the time within the hour. Will come in and they'll have stroke-like symptoms, but by the time we see them, they're back to normal. That's because that our body broke down that clot, and so as a result, we didn't develop any long-term complications. But the risk you have with this is that it could be a sign that they have a high likelihood of having a stroke within a few months. Doesn't mean they will, but we still want to get these folks to a neurologist. That way they can actually work this patient up and try to see, what could have caused this and how we can prevent it in the future. So this is just kind of an example of what could happen. So you do a CT of somebody's head on this first one, and this ischemic stroke, right? Now, so let me just talk about this real quick, and then I'll put you guys on break. So it takes time for infarction to show up on a CT. It doesn't happen quickly. It takes like 6 to 12 hours, sometimes 24 hours. And so if somebody has an ischemic stroke and you go and you do a CT of their head, they may not have any findings because it's going to take time for those cells to die, right? So say they come in within the hour, you do a CT of their head, well, it looks normal, but they have symptoms of a stroke. That's normal because it's going to take time for those cells to die. What actually really happens is that they'll do a CT of the head, they'll see that it's normal, they'll see that there's no bleeding, and then they'll do an MRI of the head, and that's a very sensitive test that you can do to look for infarction of the brain. Infarction of the brain with an MRI shows up within minutes, but CT is the first thing they do because it's a lot faster. And again, we want to make sure that they're not bleeding. That's the main thing we want to make sure. For the hemorrhagic stroke, you're going to do the CT, and that bleeding is happening right then and there, and so you're going to see this white appearance in the brain. That's your blood. And again, you don't want to give fibrinolytics with this because we don't want to make this worse. And if we give fibrinolytics, then this person is going to keep bleeding more. All right, guys, let's take a 10-minute break. So we'll pick back up at 9:50.